Morning, Dr. Lowe.
Morning, Tom.
Good to see you. Good morning, Dr. Russell.
Good morning, everyone.
Thank you for joining us.
It is absolutely a pleasure to be here. Thank you for the invitation.
I'm going to have O'Rourke introduce you here in a minute. I just wanted to pass along. I inadvertently sent you a link yesterday to a Parkinson's song. I had the wrong thing on the clipboard, so
Well, just blame it on the Parkinson's, right?
that's it. So good morning, everybody, and welcome, and thank you for joining. There'll probably others join in with us here as we go along. And for anybody who doesn't realize that today is a special meeting, we have special guests today, and O'Rourke will introduce him here shortly. But any of you that haven't been with our group before, you're certainly welcome. We meet here every week and have done so. We're on our third year every single Wednesday. And we also have a bi-weekly care partners support group that meets on a regular basis. So thank you all for being here. And I'm going to pass it over to O'Rourke.
Thank you, everybody, for being here. What I would do in the way of an introduction here, I'm going to briefly say how this has affected my life before we turn it over to Dr. Russell. And I can tell you that it has definitely changed everything about it. It's a game changer. I have been able to get in to see doctors that were months away. I was able to see a doctor 16 days ahead of my time to actually see the doctor because they interceded for me on my behalf. In fact, we wanted to go to see the doctor in Reading before he retired, the eye doctor, to make sure that his eyes were okay. And they got me in there so quickly that I was scrambling to find a place to stay and a driver for the next day. I mean, it happened that fast. And it's not just me. I talked to several other people as well. My office manager has a friend that has a condition that requires a lot of attention. She lives alone. She has limited income. And she was delighted that Vinca would take her Medicare. She then called them and they helped her fill everything out. And she said, that's such a game changer. Judy Tangbaum, who recently lost her husband, said she would have paid to have that kind of help while he was alive. And then was surprised to hear that it could be paid for. So I think I figured out what you guys do. When you call the doctor's office, it says, welcome to the doctor's office. Push 1 to find out how much you owe and if payment schedules can be set up. Push 2 if you want to find out how many months you're going to have to wait on the referral. Or push 3 if you're at another doctor's office. I think you guys go in the back door. And I am so grateful that you do. So thank you so much for coming and talking to us today, telling us how you do it and what we can do to help get more people to you. Because it is very important that we do this. And how often do you call a number and they're in the Philippines and you can't understand them? The last time I talked with one of the members of the team, he was actually in McKinleyville. One of the other nurses had been living in Reading. I mean, it's really nice that they are around and understand our problems here. So without further ado, I wish to welcome VycaCare. Thank you so much, Dr. Russell, for coming and spending time with us because it's going to really help us. We appreciate it.
Wow, well, thank you for that warm introduction, O'Rourke. It's been also a pleasure to be on this side of the doctor-patient interaction and taking care of you and your wife. So I'm really delighted to hear that that's been your experience, and also sad to hear that that was your experience before we got involved. And so I'm hopeful that we can help other folks, or at least this will be educational as to what we do. So by way of introduction, before I get started, I will share that this is very personal for me. I was in middle school when my father was diagnosed with Parkinson's disease. And he lived with the disease for about 29 years and just recently died. And he never had palliative care until he was enrolled in hospice. And that was the reason why largely I changed my career from working in the emergency department to doing a fellowship in palliative care, is because I saw all the gaps firsthand in the care that he received. And I think things could have gone differently had someone been involved in treating him from a palliative care perspective earlier. So this seemed like a natural opportunity for me to join you guys and hopefully explain palliative care and demystify it a little bit. I did prepare some slides. Is it okay if I share my screen, Tom?
Oh, yeah, absolutely.
Okay. I don't want to make this a PowerPoint heavy thing, but I just did want to prepare this. It's hopefully going to be somewhat self-explanatory too, so I can share these slides with you and you can pass them along to anyone who wasn't able to join. So I live in the Portland metro area, and like O'Rourke said, many of our team members live in Northern California, and we have been filling in the gaps. Palliative care, I'm going to speak about it more generally, but also during the setting of the pandemic has been incredibly helpful to have this telehealth platform, because these gaps in care have become more pronounced, especially in places which have already suffered sort of shortages of medical facilities and personnel. So I will talk more specifically about just palliative care in general, though, but just those general comments also about where we are now. It's even more helpful that telehealth palliative care exists. And so I'm just glad that we're able to be available, especially for people in rural Northern California. This is a long paragraph, but this is from our summary article about palliative care specifically for patients with Parkinson's disease. And I just wanted to highlight that the first line is what I believe to be true, having lived the personal experience as a family member of someone with Parkinson's disease, but also having been a palliative care physician for a number of years now. And that's palliative patients with Parkinson's benefit from palliative care in view of the impact of the disease. So the emphasis here is on early, and you can read this later at your leisure when I send out the slides. Taking a step back though, what is palliative care? This is a word that is commonly stigmatized. It is something that people don't really have a clear sense of what it is. It's kind of not a common word in daily use, so that's understandable. It was actually developed as a bit of history by a gentleman who is a urologist named Dr. Balford Mount, and he was a urologist in Canada. And this is early, I mean, hospice care as its modern form came to be in the 40s and 50s, so it's relatively new, but even palliative care is more new. And palliative care was developed because there's clearly some people that need, many people actually, who need support, who are not anywhere near the end of their life. And so that's what palliative care is, if you could think of it as a nutshell, is support for people. And that can be support for people in terms of treating symptoms. It can be support for helping them to get into appointments with economic issues, finding caregivers, all things of this nature, but it's all very much individualized. But we serve, in addition to whatever physicians and other healthcare providers, physical therapists, occupational therapists, we do not replace anyone. We just are an additional sort of epoxy that fills in the cracks between all the fragments of your healthcare experience. We have a team. I think O'Rourke was alluding to that. So we have a nurse and a social worker that are assigned for all the patients that I am predominantly in charge of. They handle things like O'Rourke was saying in terms of difficulty with referrals or getting into specialists or obtaining certain pieces of medical equipment. It could be anything, but it's all about treating a patient. So that's what I say over and over is when people say, what like is your specialty? And I explain it, they say, how do I think about you? I'm like, I treat patients, not diseases. So our focus is on your quality of life, not on your brain disease, or if you have other diseases, heart disease, lung disease, whatever the case may be. So the useful metaphor too is that if you have anyone who's raised or even cared for in a short setting, like more than one child, it's hard to do a good job of looking after multiple kids simultaneously. So we're sort of looking after you as a person, and then your specialist is allowed to look after your disease. And that way they're not distracted from potentially offering you new therapies or thinking about how your medications could be adjusted to better control your symptoms, minimize dyskinesias, things like that. So that is sort of an overview of what we do. But I guess in general, if you ever hear the term palliative care, it shouldn't be something to be afraid of. It just means support. And you can always replace the term palliative with support. Who can benefit from, and can everyone see the slides? I'm sorry, I should make sure.
Yes.
Okay, good. Okay. So this is a short one. Anyone can benefit from palliative care if they're suffering from serious illness. And it's not just the patients themselves, but it's also the family members. I don't have to explain this to you because you're all living this experience, but it's very difficult when you have a progressive neurologic condition to explain how you may seem to be a different person, may be feeling like you're falling short in terms of your role as a partner to your spouse. All those kind of feelings are natural. And by meeting with patients, their spouses, their family members, people are able to express their feelings. We give space for that. Our visits are much longer usually. We don't have a specific agenda under them, what's getting at what's going on with quality of life and people as a whole. And so there's been many studies that show that the family members of patients that are in palliative care also have better reported quality of life scores, better mood, less stress, better sleep, all those sorts of things. So the difference between hospice and palliative care is a common question. So palliative care is the larger umbrella. Hospice is a small portion of palliative care. And hospice care is care that is devoted to people who want to focus on comfort and are likely in the last months of their life. So this is a benefit. Hospice is not a place, but it's a set of services. Usually it is offered through Medicare for folks that are over 65, but if you have another insurance, they will also usually have a hospice benefit that's very similar to Medicare. But what it is a lot more attention than you would typically get with palliative care. O'Rourke can speak to our sort of frequency of visits, but it's usually about every month that someone from our team will check in. We can do them sometimes a little bit more frequently, but based on the number of patients I'm caring for, I can see people about once every 3 months. If people are really in a serious transition period, or they're very symptomatic from getting things like chemotherapy, if they're a cancer patient, then sometimes you can squeeze them in and see them about every 2 to 3 weeks. But in hospice, you're going to get visits at your home from a nurse every week, usually 2 times a week. So it's a lot more attention, but it does have strict eligibility criteria. So that is the main difference between hospice and palliative care. Does anyone want to ask any questions about that right now? Because this is such a major point of confusion. But I think the main take home is that what I'm offering and what I'm doing for work is very different from hospice in terms of the amount of attention he gets, but it's also very different because we're supporting him, but he's not giving up any of his other specialists.
You also have a special member of the team, the chaplain.
Yes.
And I think you need to mention that because that's an important part of it.
Sure. And thank you for bringing that up. So I was going to talk about the other members of the team later, but the chaplain is one that is, what we call it spiritual care, because chaplain, for people depending on what their, experience with organized religion has been throughout their life, can be either a positive thing or a negative thing. But chaplain is chaplaincy, as it's used in palliative care and hospice, means that it's a spiritual support person. So they function as almost like a therapist, but they're just there to listen rather than coach anyone about specific prayers or what happens or doesn't happen after you die. So, I mean, Aurora can probably speak to his experience with our chaplain and how open they were, but their job is really to just support people that are suffering spiritual pain, insofar as I support people that are having physical or psychological pain. Has that been your experience too, Aurora? I hope.
Absolutely.
There's been studies that show that when you sit down and go to an average doctor's appointment, they listen for about 25 seconds before they interrupt. And I think anyone who's been to any primary care doctor or specialist recently can probably relate to that. So the large part of the therapeutic interaction that we have is just giving space for people to express what their experience is. So there's no eligibility criteria for getting palliative care. Our patients range from having Blue Cross to California Medicaid to Partnership of California, and many, many patients with Medicare. O'Rourke, have you ever seen any out-of-pocket expenses for any of our services?
None.
Okay.
None whatsoever.
And I really don't know anything about that. I get paid the same whether I'm, seeing patient for 20 minutes or an hour. I just do it based on what the patient's needs are. So there's no incentive for any of us to do any more than what we're doing. And what I've heard from most Medicare patients is they've not had any out-of-pocket expenses. So these are the services that we offer. And this should be any really palliative care service. I'm not just speaking about VycaCare specifically, is that it's an interdisciplinary team with a social worker, a nurse, a chaplain, medical assistants, and then usually a physician. So we help with something called advanced care planning, which everyone, including myself, puts off because it's not a fun thing. Even if you're not someone who doesn't mind thinking about death, it's still not a fun thing to sit down and fill out paperwork. But we have a social worker that carves out a special appointment and demystifies these legal forms to make sure that they're accurately expressing your wishes. I think this is the most important thing to do for your family as an act of love, because when things go awry with our health, it can be this slow pattern of decline that people expect with Parkinson's, but people can still have falls and have strokes and other sources of acute changes in their health. And if, God forbid, you end up in a place where you can't speak or you're on a ventilator and your family has no idea what your wishes would be in the situation, is extremely stressful on them when the doctors turn to them and ask for guidance on what to do or what not to do. So please, for yourself and for your family, make some time to get your wishes in writing. If you go just Google general advance directive, you can start to fill one out. The POLST is a form that's commonly considered a DNR form. You don't have to select DNR, meaning do not resuscitate. You can select that you want everything done, but at least doing that, the POLST form is available on the California website, california.gov, and it needs to be signed by a healthcare provider to be valid, but even just filling it out at least gives your family some guidance as to what you would want if your health suddenly changes. So we, to O'Rourke's point with his experience, offer help with coordinating care. Our nurse can get in, like he said, the back door. I like that as a metaphor. A lot of the time, especially when you're dealing with not even people and just leaving messages. We help with medication and non-medication sort of interventions for improving quality of life. That can be dietary interventions, that can be recommending different types of therapy, physical therapy, specific exercises, and again, spiritual care and chaplaincy support. So what we don't do, we don't adjust medications that are prescribed by specialists. In the case of Parkinson's, that would be any of the dopaminergic agents. And that's not because we don't have familiarity with them, but that's sort of somebody else's turf. And it gets complicated if there's several cooks in the kitchen, so to speak. Similar, like the same way we don't adjust chemotherapy. We can have conversations with your specialists if it seems like there are gaps in communication or they're not listening or understanding what the actual issues are. And that's sometimes the way that we support appropriate medication adjustment. We generally don't prescribe controlled substances for people that are not near the end of life, meaning they're not having severe pain, anxiety, restlessness in the very end of life. That's really the realm of hospice. And also there's been some recent changes in controlled substance prescribing via telehealth only. So we have legal hurdles to get through, and pharmacies are not filling telehealth prescribed controlled substances in increasing amounts. We don't evaluate new conditions. We don't order tests. We don't make new diagnoses. So a lot of times patients will come to us and they'll have some, in the setting of Parkinson's disease, for example, they'll have potentially some abdominal pain. And as many of you probably have experienced, constipation is an unfortunate consequence among many of them for Parkinson's patients. So I can say, I don't know the cause of your abdominal pain, but as long as it's not super severe and it came on just, yesterday out of the blue, that it's reasonable to try some things for constipation. I'm not diagnosing that as the ultimate cause, but I can say that if your abdominal pain completely goes away when we treat the constipation, that's pretty good. If it doesn't, I'm not going to be the one who orders an X-ray or a CAT scan or blood tests to figure out the result of that. So I think this is also important to understand, and we do send a lot of patients that come in depending on what their goals are. If their goals are to continue to extend their life as much as possible, we send a lot of patients that have new symptoms to the emergency department, because that's really the place that acute symptoms have to be worked up these days. So I have a couple more slides. I just wanted to pause there and see if anyone had any questions. So just a quick few myths. Palliative care means that I'm dying. Well, insofar as we're all dying, that is true, but it doesn't mean that you're any closer to death than if you're not getting palliative care. My father was getting hospice care even for several years, so you can get hospice care for a long period of time, and palliative care certainly has no effect on your duration of life remaining. It does actually, in a lot of studies, show that patients live longer because, to O'Rourke's point, palliative care supports them. They have better physical, mental, emotional well-being, but they also can have additional layer of support in terms of catching issues that may lead to, for example, if they're on a medication and it's affecting their balance, changing that medication before they have a fall, break a hip, etc. Getting palliative care will shorten my life. I actually just touched on that, but that is certainly not true. And I mentioned those studies that show that patients live longer with a variety of different conditions if they are enrolled in palliative care. Hospice means giving up. Again, a hospice also has been shown not to shorten life expectancy and may actually extend life expectancy for a lot of conditions. A perfect example of this is when patients are on a lot of medications and their medications are causing such bad side effects that they are not able to be up and active. They're not eating normally because of nausea or whatever the case may be. Hospice stops medications that are in patients when it's clear that they're not going to extend patients' life, and they therefore will not get the side effects of those medications. Hospice is not a permanent choice. So if there's ever a period where you or a loved one is considering hospice, you can always try it if you're eligible and they will enroll you. It can always be stopped. You can say, I want to go to the hospital because I'm having chest pain. I want to go to the hospital because I broke my hip, or I want to go back to my oncologist and try more chemotherapy. All of those are totally reasonable. It happens all the time that people start hospice and then stop it. But more often than not, people will tell me when I'm caring for them under hospice, which I do also hospice care, is that they wish that they had chosen it earlier. But it is understandably a stigmatized thing, so I'm trying to demystify that a little bit. Hospice does require foregoing hospital care, most specialist care. It doesn't cover medical procedures or surgeries, so that is important to know. But again, you could, if you are in hospice, you can stop hospice and get care for whatever the condition may be. You would just go right back into general Medicare, basically. Hospice only gives patients morphine. We treat symptoms in hospice, but we don't force any kind of medication on people. Most hospice care, over 90%, is delivered in a home setting, whether it be at a care home or private home. And that means most of the medications are given out not by hospice nurses or care providers, but by family members or caregivers in a nursing home. So you're not going to force any medication on you. It's entirely up to the consent of you and your family. And most patients on hospice do die quickly in America, but that is only because patients wait very long to take advantage of the benefits of hospice care. So it is also very dependent on what condition you have. So patients with cancer will tend to die very quickly towards the end of, as soon as the cancer has spread to the point where they've lost function, they tend to die relatively quickly. Whereas with neurodegenerative diseases, that process is usually much slower. And I've had to actually, always been unfortunate, but because of the eligibility criteria for hospice, actually stop hospice services for many patients or discharge them from hospice care. They usually can re-enroll pretty quickly, but because they've been on hospice for 3, 4, 5 years. So especially in neurodegenerative disease, it's a tremendous amount of extra support, especially if the goal is to just be comfortable and be at home. And patients who are enrolled in hospice, their family members do much better. And I can say that certainly has been the case for my mother since my father died, that the grieving process has been, I wouldn't say easy, but it's been eased by the fact that he was getting hospice care for the last years of his life. And the final slide I would leave you with is our website that goes through all about our program specifically and answers some of the same general questions about palliative care. I hope if you don't choose VycaCare, that you would consider palliative care from another service. I know that there is very limited other services in the area, other than inside at St. Joseph Hospital. They have an inpatient palliative care service, and I'm not sure how many patients at this point they're following outside of the hospital. So that would be more like, treating symptoms while you're hospitalized, but then it would be you on your own again once you leave the hospital. But CAPC is the Center for Advancement of Palliative Care. It is a website that has, this is their patient website, getpalliativecare.org, and it answers a lot of questions about how to access palliative care and covers basically the things that I covered. So I wanted to tailor this a little bit to obviously Parkinson's, because this is the group that I'm speaking to today. And this is, again, what I wish my father had probably a decade before he actually enrolled in hospice. And that's all I have prepared. So I'm happy to stick around. That was so good, exactly 30 minutes. And I have another 15 or 20 minutes if anyone has questions. Otherwise, I can leave you with the slides and the rest of your meeting time.
Well, I think one of the things, go ahead.
I just wanted to mention I've muted some folks, so you may need to unmute yourself to ask your question or just hold down the space bar to talk to Dr. Russell.
I guess my question is, you said that there are pretty strict requirements regarding hospice and Parkinson's. Could you expound a little bit on that?
Yeah, absolutely. That's a great question. So hospice requires that a physician certify that your life expectancy is 6 months or less if the disease process follows its predicted course. That means that there's obviously no one has a crystal ball, and that's why people live on hospice often for multiple years. But there are disease-specific requirements for Parkinson's disease, which requires that essentially people are close to bedbound. Often they have cognitive issues as involved as well, or if they're having things like difficulty with swallowing and getting pneumonia or getting bed sores, things of that nature. So there are also other diseases that people with Parkinson's get, obviously. So if you have heart disease, lung disease, kidney disease, in addition to Parkinson's, then your eligibility could be earlier. Again, I would also say that it is because a physician is certifying it, they have their discretion to enroll people. If they say, these are the formal criteria, but I think this person, for whatever reason, they've lost a bunch of weight recently, I think this person probably doesn't have more than 6 months, they could certify you, but it's ultimately going to be a hospice program by hospice program decision. So a lot of our patients get hospice care from Heart of the Redwoods, and I've been surprised and in both directions where I felt someone was probably within the last 6 months of their life and they've not enrolled them, and other times when I didn't think so and they have. So the only way to know for sure if you're eligible would be to have someone place a hospice referral. A nurse would come to your home and evaluate you, and then they would be able to better describe the specifics of their program. And if they don't give you a satisfactory answer, you could try another hospice program. There's not a ton in Northern California, but there are options.
I do have one more question. How do if patients get to, this is for my wife, if patients get to the point that they're not able to move around, is there specific types of equipment that you recommend for, like a hoist and so forth, for moving around?
Yeah, I mean, it would depend a little bit on the specifics of the space, but the Hoyer lift is generally the standard. That's an HOYER. It's an electric lift that sort of has a harness attached to a crane. And that's nice because it doesn't involve any manual lifting. It's hydraulic. And physicians can place a DME, a durable medical equipment order for that, and that is usually covered by Medicare, as long as there's a qualifying diagnosis, which certainly Parkinson's disease would fall under.
Good.
And we've ordered those for many patients as well. So
good. Thank you.
One of the things that I find very comforting is they have all my notes, they have all the charts, they have a list of meds, they have it all. If the caregivers need to call in 24/7 or whatever happens, they've got all the information right there. And I find that very comforting.
You've mentioned that you coordinate care between specialists and the palliative care team. Does there ever develop any territoriality between your team and the primary care provider?
That's an interesting question. Occasionally, if we're trying to change anything that they're closely monitoring, then that can be problematic. But we send all of our visit notes to them. We do have the same communication issues that you struggle with to a certain extent. They're probably less pronounced, but I don't get a call back from every doctor I try to reach. So we do send them the notes. I do ask, the patients keep track of anything that we're starting for them to and discuss them with their primary care. But we don't change medications for diabetes. We don't change medications for blood pressure unless someone's having real problems with low blood pressure, for example, in which case we might say tell someone to hold a medication. But that's a pretty rare thing where there's any conflict. They're usually supportive and appreciative of what we're doing because they're trying to, you know, manage way more than they can do in a 15 or 20 minute appointment.
Thank you.
Mm-hmm.
Now,
Can I have a few-
chance.
If I
Go
can
ahead,
have
I'm
a few
sorry.
questions? One comment and a few questions.
Okay, whatever order you like to go.
Well, it seems to me if you were having a simple description of what you do, it's like you're an ombuds person or ombuds team. And basically you're there to help the patient do whatever needs to be done to help them live well. Is that a good description?
I think it is, but I'm not sure ombuds person is more accessible as a word than palliative care for the general population. So, but I know that ombuds person is sort of just a, you know, supporting everyone sort of role. So if you have experience with local government, then yes, that is a good metaphor.
Oh, okay. But is VycaCare only telehealth, telemedicine, or is it also hands-on, come into your house type of care?
So we are only telehealth based. Yeah.
So that's how you can be in Oregon, but also deal with people in California, because otherwise you wouldn't be able to on your license.
Yeah. So I have a California, Oregon, and Washington license, and I have patients in all 3 states.
Okay. And then tell me, you know, when should people be thinking about getting palliative care assistance? I mean, what would be the sort of triggering events that say, hey, I need some extra help?
Well, I would say once you have Parkinson's as a diagnosis, then it would not hurt to have to be enrolled, because it's involved the whole sort of initial screening about like, what is your life like? Where do you need assistance with anything? Do you fall? How is your, you know, walking patterns, sort of those kind of things? What is your family support system? What is the amount of like stairs you have to navigate in your home? How far do you drive when you drive? Like all these kind of things are very personalized. So we can, it's sort of upstreamism. We can see where the problems are going to be likely, you know, even if they're 5 to 10 years down the road, the earlier we get involved and the earlier we can make an intervention, the more we can forestall those problems by, you know, recommending exercises or PT or, you know, recommending considerations for alternative like age-in-place homes or things like that. You know, there's a lot of things that can be done before the horse is out of the barn, and it's kind of hard to do it too late. So I can't ever say it's too early.
Okay. But there was just a question on, you know, when should people be thinking about, okay, this might be something that might be beneficial. And then how does actually one sign up? So let's say you're covered by Covered California, or let's say you're covered by Kaiser, or let's say you're covered by Sutter Health down here, or you're with the UC Davis healthcare system.
Mm-hmm.
How does it work to also enroll in the palliative care service like VycaCare?
Kaiser is an interesting question. I don't think we have any Kaiser primarily patients, but I definitely have many patients that get specialist care at UC Davis, UCSF. We don't directly like interact with them in a way that they would be threatened or territorial about it. And there's an extreme shortage of palliative care services nationwide. So there's no competition for patients because patients are in abundance, and most palliative care services are truthfully overwhelmed. I don't know if that answers your question directly, but the VycaCare website that I put up here is just VycaCare.com. I can share that again, but it's It is the way to access the. It is the way to access. Are you still seeing my slideshow? No, here it is.
No.
So this VycaCare.com is how you can get more information about enrolling in our program. If you want to go to getpalliativecare.org, then they can talk to you about other ways to enroll. If you're close to UC Davis or UCSF, they certainly have palliative care programs internally, and in the larger cities, then there's usually outpatient palliative care programs where people would get in-home visits. To be honest, the frequency of visits is usually about the same. It's usually not more than about monthly, with a physician or occasionally nurse practitioner. PA might be the one who comes to your home.
Okay. Thank you.
Yeah.
If there were one or two, in terms of palliative care, if there were one or two things that would go to the top of the list that really made a difference for patients, in your experience, what would those be for Parkinson's patients?
I mean, it's going to sound sort of mundane, but it's having conversations about the difficulty of the experience, both for patients and family members, to normalize it. People feel a tremendous amount of relief to be heard, and it's preparing for the future in terms of making sure that if people don't want intensive care at the end of their life or to die in the hospital, that they have paperwork to reflect that, so their loved ones are not burdened with. I mean, it's a big thing as a doctor when I approach someone and say, do you think your mom wants to be on a ventilator or not? And, they're thinking about, like, I'm making the decision to end my mom's life or my wife's life or son's life or whatever the case may be. So anything that you can do to prepare for that. So those would be the main things. In terms of symptoms, it's just Parkinson's is a very different disease for every person. So it just depends on which symptoms they're struggling with.
How big of a factor is exercise in terms of not prevention, but palliative care?
Well, strength training, specifically like resistance training, has been shown as one of the most important things, if not the most important thing you can do to mitigate the progression of all neurodegenerative diseases, including Parkinson's disease. The second, for Parkinson's specifically, and then for dementia, if dementia is a part of Parkinson's or in Alzheimer's, then social interaction is a close second.
Okay, good. Thank you.
Yeah, these are great questions. I have a few more minutes. Does anyone else want to share any comments or questions? Otherwise, I definitely leave my slides with Tom.
Okay.
Tom, you seem like you're the head of the ship. Is that right?
Well, I'm the one doing it anyway.
Okay. Well, thank you for doing this.
Yeah, we really appreciate you being here. So basically, what I get is that we with Parkinson's are probably quite eligible through Medicare. I'm sorry, I'm getting a lot of. There we go. We're covered through Medicare and our insurances, so that's probably not an issue. And so, yeah, anything else, O'Rourke?
25 seconds before the doctor interrupts the patient.
Yeah.
Boy, that's amazing that happens that quick.
Well,
all I can say is I'm certainly grateful to one of my caregivers that found this whole setup for us. At first I was almost, this is too good to be true. Somebody will actually advocate for you. But it is true. It truly does work. And that's why I wanted the doctor to come and share with you so that you had the information if you wanted to do anything with it, because it's a game changer.
Very good. Well, again, Dr. Russell, thank you very much for being with us. It was very informative. My wife is over here taking notes. And, one of the things that for me with Parkinson's is I want to make life for my care partner as easy as I possibly can. And, to bring in help like that, I think would be very beneficial. So thank you. I feel very much more informed. And just for the rest of the group, we'll just go ahead and stay on for a little bit longer. If people want to check in or have any issues they'd like to talk about. And again, Dr. Russell, thank you very much for being with us.
Thanks for the invitation. It's so nice to meet you all.
Thank you, Dr. Russell. I sure appreciate you doing
Excuse
this.
me?
Yes, thank you. It was wonderful. Thank you.
Okay.
Bye-bye.
Now I'm going to try and figure out how to turn off the recording of this. I think that's